Hello viewers, in the last video we studied about the outcomes of acute inflammation. Today we are going to study about the morphologic patterns of acute inflammation. So what are the morphologic hallmarks of acute inflammation? These are vasodilation of small blood vessels and accumulation of fluid and leukocytes in the extravascular tissue. So these are the general features but there can be some special patterns of morphologic patterns of acute inflammation depending on the site of involvement of tissue, depending on the causative agent, and the response, the severity of the inflammatory response. And why is it important to study the morphologic patterns of acute inflammation? Because they provide some clue or information about the causative agent, So these are the morphologic patterns of acute inflammation: serous inflammation, fibrinous inflammation, suppurative or purulent inflammation and abscesses, ulcers, pseudomembranous inflammation, Cataral inflammation and hemorrhagic inflammation. So we start with the serous inflammation. Serous inflammation. So it is characterized by accumulation of cell-free fluid in the spaces created by tissue injury, cell injury or the tissue injury, and the body cavities which are lined by peritoneum, pericardium, pleura. Now the accumulation of fluid in the body cavities is called as effusion. Now serous effusion in the body cavities, it can occur if there is increase in vascular permeability. So the fluid is plasma derived, it is derived from plasma, or due to secretions from mesothelial cells, mesothelial cells. The mesothelial cells are lining these body cavities. So it can occur as a result of local irritation or due to some hydrodynamic or hemodynamic derangements. So the cause here will be non-inflammatory. So when there is increase in hydrostatic pressure as occurs in cardiac failure, or when there is decrease in plasma osmotic pressure, it is seen in liver diseases, kidney diseases. So then there is accumulation of fluid in the body cavities. and this fluid is poor in cells, means there is only a very few leukocytes are there, very few leukocytes. Now another example is skin blisters. Skin blisters. Now skin blisters can occur as a result of burns, viral infections. Skin blister represent this serous inflammation in which the serous fluid, it accumulates in the epidermis or just beneath the epidermis. So now we will see the morphology of skin blister.
This microphotograph shows the morphology of serous inflammation. This is a low power view of cross section of a skin blister showing the epidermis separated from the dermis by a collection of serous fluid. This is the epidermis, this is the dermis, and this is the serous fluid. So the serous fluid is cell poor fluid. It contains very few leukocytes and it doesn't contain microbes.
Next is the fibrinous inflammation. Fibrinous inflammation. So in this, fibrinous exudate develops. Fibrinous exudate. So fibrinous exudate occurs when there is marked increase in the vascular permeability, or when there are large vascular leaks. So the fibrinogen, which is a larger molecule, it leaks out. Fibrinogen leaks out of the vessels, and if there is procoagulant stimulus, it is converted into fibrin, and it is deposited in the extracellular space. Now this fibrinous exudate, it is characteristic of inflammation of the lining of body cavities. For example, the meninges, the pericardium, pleura. Now this fibrin, it can be lysed by the process of fibrinolysis, and it may be cleared by macrophages. But if it is not cleared, then it stimulates the ingrowth of fibroblasts, and then healing occurs by scarring. So in this scarring, the fibrinous exudate is replaced by fibrous tissue, and this is called as organization. organization. Now in the pericardial space, if there is this fibrinous exudate and this scarring occurs, it can lead to obliteration of, first of all, it can lead to the fibrous thickening of the pericardium and the epicardium, and it can obliterate the pericardial space. It can lead to obliteration of the pericardial space. Now let us see the morphology of fibrinous inflammation.
Fibrinous pericarditis. The image A shows the gross appearance of fibrin deposits on the pericardium. Normally the pericardium is shiny and glistening and has a smooth appearance. But here in fibrinous pericarditis, the pericardial texture is rough and granular. This appearance is often called bread and butter pericarditis. Image B is the microphotograph showing the histological appearance of fibrin exudate, the area that is denoted by letter F, which appears like a pink meshwork of threads or as an amorphous coagulum overlying the pericardial surface. This area is denoted by letter P.
Next is the suppurative or purulent inflammation and abscess. So suppurative inflammation is characterized by production of pus. Pus, what is pus? Pus is an exudate. Pus is an exudate and it consists of neutrophils and the necrotic or the liquefied debris of cells and edema fluid. So what are the causes of suppurative inflammation? Suppurative inflammation is caused by bacterial infections which produce liquefactive tissue necrosis. Liquefactive tissue necrosis. And what are the bacteria? These are pyogenic bacteria. For example, Staphylococcus or Staphylococci, Streptococcus pyogenes. And what are the examples of purulent inflammation? Acute suppurative lymphadenitis, acute appendicitis, pyogenic meningitis, lung abscess. These are examples of this purulent or suppurative inflammation. So what is an abscess? Abscess. So abscess is a localized collection of pus. It is a localized collection of pus that is caused by suppuration buried in a tissue, organ, or in a confined space, The abscess, the central zone of an abscess, it is composed of a liquefied mass that has necrotic leukocytes, mainly the neutrophils, and the necrotic tissues, cells, their debris, and around this zone, around this liquefied zone, is an area of neutrophils that are viable, and around that a zone of healing is there, where we can see dilated vessels, proliferating fibroblasts, parenchymal cells, and this indicates chronic inflammation and repair, and ultimately the area, whole area or the area of abscess gets walled off and is replaced by connective tissue. Now let us see the morphology of suppurative inflammation.
Purulent inflammation. Image A shows the gross appearance of multiple bacterial abscesses in the lung in a case of bronchopneumonia. These are the abscesses. These abscesses are produced by seeding of pyogenic bacteria into the tissues. Image B shows the microscopic appearance of an abscess. The abscess contains neutrophils and cellular debris and is surrounded by congested blood vessels. These are the congested blood vessels.
Next is the ulcers. What is an ulcer? Ulcer is a local defect or excavation on the surface of a tissue or organ that is produced by sloughing or shedding of necrotic and inflamed tissue. So this ulcer can occur only when the inflammation and necrosis are on or near a surface. So ulcer is common in the sites, the mucosa of mouth. The aphthous ulcers are seen in mouth, the stomach, intestine, the GIT. See. So here peptic ulcers in the stomach and the duodenum. And ulceration can also be seen in the skin and the subcutaneous tissues of lower extremities, in individuals with conditions that predispose to vascular insufficiency, What are the examples? Diabetes, for example, sickle cell anemia, and also in peripheral vascular diseases. So for morphology, let's take example of the peptic ulcer. So here both acute and chronic inflammation coexist. In acute stage, so ulcer has the margins, these are the margins, and this is the base. So in acute phase, there is intense polymorphonuclear infiltrate in the margins of the ulcer, and in chronic phase, or if we see the base and the margins in chronic phase, there is fibroblastic proliferation. We can see fibroblastic proliferation, scarring, and infiltration by chronic inflammatory cells, which are lymphocytes, macrophages, plasma cells. So let's have a look at the morphology of peptic ulcer.
The morphology of an ulcer. Image A shows the gross appearance of duodenal ulcer. Image B is the low power cross-section view of a duodenal ulcer crater. So this is the base and these are the margins. So it shows acute inflammatory exudate in the base.
Next is the pseudomembranous inflammation. So in pseudomembranous inflammation, there is acute inflammatory response to a necrotizing toxin, For example, the diphtheria toxin. And there is formation of a false or a pseudomembrane, and this pseudomembrane is composed of fibrin, the necrotic tissue, and leukocytes. Another example is Clostridium difficile toxin, which produces pseudomembranous colitis. Next is the Catarrhal inflammation. So this inflammation involves the mucous membranes. There is inflammation of the mucous membranes, and there is enlargement of the secretory cells, and there is secretion of copious amounts of mucus along with debris, and there may be serous or purulent exudate. Examples of this inflammation are catarrhal rhinitis, catarrhal conjunctivitis, and last one is the hemorrhagic inflammation. inflammation. So this inflammation is associated with microvascular bleeding. So in the exudate there is high RBC count. Example is hemorrhagic pancreatitis. So in today's lecture we studied about the morphologic patterns of acute inflammation. In the next video we will be starting with the chronic inflammation. I hope you like the video. For more such videos, please subscribe my YouTube channel and do not forget to like and share my videos. Thanks for watching.